Welcome. This is going to be 1330, which is pediatrics at the college I teach, covering chapter one, which is perspectives of pediatric nursing. So, when we talk about childhood health, the World Health Organization gives us a great definition that health is a state of complete physical, mental, and social well being. It's just not merely the absence of disease. So, the goals of healthcare for pediatric nursing, we want to do health promotion. We want to integrate surveillance of physical, psychological, and emotional changes that can occur in human beings between birth and the end of adolescence. Nutrition is an essential component for health and growth and development. Children establish lifelong eating habits during the first 3 years of their life. And as a nurse, it's important for us to educate parents on the importance of nutrition. And then we also do a lot with oral health. It's an essential component of health promotion throughout infancy, childhood, and adolescence, preventing dental caries and developing healthy oral hygiene habits. Must occur in early childhood. We know that dental caries can create significant problems throughout lifetime if they're not, handled in childhood. So, what are the issues affecting childhood health right now? Childhood obesity is the most common nutritional problem amongst children in America. They are considering it an epidemic. Overweight youth, especially children in Hispanic, Afro American, Native American descent, all have an increased risk for developing high cholesterol, insulin resistance, which can lead to diabetes, hypertension, and heart disease. So, nursing intervention should focus on prevention. We also look at injuries. Injuries are the leading cause of death in children older than 1 year of age, with the majority being motor vehicle injuries. We also need to realize that as children grow older, the percentage of death from injuries increases. So we just need to make sure that we're keeping them safe. And then we also want to look at their developmental stages and their environment. Um, we notice we can have specific injuries at given ages that are completely preventable. So when we think about, a little baby that's starting to crawl, we need to start, safety proofing the environment, the house. When we have a kiddo who's getting a little bit older and might be going out on roller skates or bicycling, we want to make sure they're wearing those knee pads and those helmets. Violence seems to be part of a majority of American households. It can be through televisions, commercials, video games, watching the families. We're noticing that children are slowly becoming desensitized to violence. Violence also permits, it happens at the schools. And then we always have concerns about, like kids that have guns and illicit drugs and things like that available to them. Child homicide is very complex, but it's more frequently happening. Substance abuse, children that grow up in the homes with substance abuse have an increased risk, but sometimes when they're in a very sheltered home and the families do not talk about it, when they get exposed to it with friends, they have the potential to use it and not be aware of really what they're doing is not right. Vaping has become a national epidemic. It represents the largest increase in adolescent substance abuse recorded over a 1 year period when this book was published, and we used the Wong. Um, and then just closing out this slide, 1 out of 5 children experience mental health problems. 1 out of 10 has serious emotional problem that affects daily functioning. Many adolescents with anxiety disorder and impulse control disorders like ADHD um, they're developing during their adolescence and even younger. So nurses need to be alert of the symptoms of mental illness and potential suicidal ideation that can come with it, and be aware of potential resources that we can integrate with their care services. So this slide's talking about childhood injuries, risk factors. We have several factors. Um, and when we talk about developmental characteristics, we're looking at, is there a mismatch between the child's developmental level and this skill that they're doing, and therefore we have an increased risk. All children are naturally curious to explore their environment, so we need to make sure that that environment is safe. I kind of just noted that in the last slide that, once we have a kiddo who's, crawling around and exploring, we need to make sure that that level of the environment is safe for them. Children are always going to have the desire to assert themselves and challenge rules. So we just need to make sure that, when they're doing that they're still safe. In older children, the desire to seek peer approval and acceptance is stronger. So again, if we have parents that do not feel comfortable talking about those risk factors, their children could be exposed to it through their peers and then be at higher risk. Cognitive characteristics. So we're going to get into Piaget's and Erickson's in a few more chapters. But when we look at Piaget, we talk about the sensorimotor stage. And this is when kids are really exploring their environment through taste and touch, which means that that little infant's mouth is going on things that can become a foreign body. It could poison them, it can cause other complications. Young children, um, they're starting to understand object permanence. So if something rolls under the table and it's no longer in their field of vision, they know that it's still there. So they're going to actively search for objects. Um, and sometimes they don't quite understand the consequence of the danger. So they see that the the handle to the pot is on top of the stove, and they know that that pot is still attached to that handle because they have object permanence, and therefore they know that if they grab that handle that they get that pot, and sometimes that can lead to something falling down on them. That's kind of what that's talking about. School age children are starting to transitional their cognitive process. They're not fully able to comprehend all types of relationships, and this can lead to dangerous acts without detailed planning or regarding of consequences. And then adolescents are in their formal operations. They're again preoccupied with their peers. They have abstract thinking, but really a very minimal insight of reality, and they're can feel very vulnerable. So we just need to be mindful of that. Infant mortality. So infant mortality, our infant mortality rate is the number of deaths during the first year of life per thousand births. It can differ obviously year to year. They do divide it into neonatal mortality, which is less than 28 days, and post-neonatal mortality, which is 28 days to 11 months. Once they hit 12 months, they're no longer considered that infant. In the United States, infant mortality rate was 5.8 per thousand live births, and the neonate mortality rate was 3.84. Um, those numbers were from 2017. You'd have to go on to the CDC if you wanted more up to date. Birth weight is considered a major cause of neonatal death. We know that relatively high incidence of low birth weight deaths occur in the United States. We consider it to be a key factor, and the lower the birth rate, the higher the mortality. Other risk factors that they've identified for infant mortality is children of the African American race. Males are more likely than females. Shorter gestation, right? If the baby didn't have enough time to develop, if the fetus didn't have enough time to develop and it comes out, it's at higher risk. If it was a longer gestation where perhaps it aspirated some meconium or had other complications, so shorter and longer gestation. Maternal age, right? If the mother is very young or very old, we have an increased risk of infant mortality. And then parental education, if they just, they don't have the education to know how to care for themselves, care for the baby, that can also impact and create infant mortality. Causes of death in the infant also can be attributed to congenital anomalies, and we'll talk about that as we go through the different systems, sudden infant death syndrome, and then unintentional injuries, such as, objects being left around them and they suffocate or poison or something like that. Childhood mortality is the next topic. So, childhood mortality is children older than 1 year of age. So, children from ages 5 to 14 actually have the lowest rate of death. However, a sharp rise occurs later in adolescence, primarily from injuries, homicide, and suicide. After year one, the cause of death changes dramatically with unintentional accidents. So when we're looking at after year one, those unintentional accidents can be, them drowning, motor vehicle, and stuff like that. Burning, firearms, poison. These are just some other causes of childhood death. So, the motor vehicle injuries are the leading cause of death in children older than 1 year of age. The majority of fatalities involve unrestrained occupants. If a car seat is involved in an accident, it is no longer considered safe to use. So, when children, are in a car and in their car seat and that car seat involves in an accident, that parent needs to be given education that that car seat needs to be disposed of and they need to obtain a new one. Motor vehicle accidents are also the leading cause in males ages 15 to 24. Drowning is another leading cause of death. Children left unattended around waters, even when they're shallow waters, because it really just takes a mouthful. Other causes, burns, injuries for 1 to 14 years, leading cause of death. I kind of made note to that beforehand, right? If that child that's already developed object permanence knows that that pot is on the stove, they can reach for it, not really understanding that that pot is hot and it's got boiling contents and it's going to burn them. And then also improper firearm use. If we have guns out, loaded, safeties off, obviously, if a child gets their hands on it, they could hurt themselves, they could hurt somebody else. This is the fourth leading cause of death and injury in children ages 5 to 14. So now we're going to move into childhood morbidity. So morbidity statistics are measurements of the prevalence of specific illnesses in populations at a particular time. Childhood morbidity statistics encompass acute illness, chronic disease, and disability. Recent concerns have focused on groups of children who have increased morbidity, such as homeless children, children living in poverty, low birth weight. The term new morbidity refers to behavioral, social, and educational problems that can cause significantly alter a child's health. 8% of childhood illnesses are attributed to infections, with respiratory tract infections occurring 2 or 3 times more. Childhood morbidity, um, is just something that we need to be prepared for. We want to reduce if we can. So if we have a child that we know falls into some of these categories, we want to hook them up with services to help them. Now we're going to move into the art of pediatric nursing, focusing on philosophy of care, role of the pediatric nurse, and then I'm going to touch upon research and evidence-based practice. So family-centered care is really important concept that we use in pediatrics. If you've already taken fundamentals or an adult med surg, we talk about patient-centered care, right? And Way back, long time ago, we did more physician-centered care, where we would just look at the client and their illness, and that was it. You were here for an MI, and this is what an MI gets, and we didn't really look at the patient holistically. When we started practicing patient-centered care, we looked at the patient as a whole. We looked at how it impacted all aspects of their life, not just, the disease itself. So when we're talking about family-centered care, this is an approach that has the family is the constant in the child's life, and therefore we need to support, respect, and enhance the family and the family unit. All family members should be included. This is siblings, right? Now, obviously, if the sibling is a younger sibling, you're going to have to involve them at whatever their developmental stage is. I use the example of new diabetics, right? If we have a 7-year-old who's a new diabetic and they have a 5-year-old sibling, we're not going to expect that 5-year-old sibling to be able to do, glucose checks and, administer insulin and keep track of carbohydrates. Like, that's not going to be the sibling's role. But we might teach the sibling, like, if your sister starts getting like really tired or she's not acting right, you got to come get an adult. All right. So we just need to make sure that everybody in the family is included, and they're all included within their developmental scope. The philosophy of family center care recognizes again that the family is the constant. We want to make sure that we're using the two basic concepts of family center care, which is enabling the family. And we do this by creating opportunities and means for all family members to display their current abilities and competencies and to acquire new ones to meet the requiring new ones to meet the needs of the child. Empowerment describes the interaction of professionals with families in such a way that the families maintain and acquire a sense of control over their family lives, acknowledge positive changes that result from helping behaviors, and that foster their own strengths, abilities, and actions. And when you think about, all of those words and what that means, you just really want to make sure that when that family leaves with that kid, that new diagnosis is going to be something that they're going to feel very strong, able, and confident in caring for. They know what they need to do, they know what their follow-up is, when to seek immediate medical attention. And you just want to make sure that that child is going to be safe. The next thing we're going to talk about is atraumatic care. And atraumatic care is providing care in a therapeutic way that does not cause harm to the child. So it has three principles to it. Number one is preventing or minimizing separation from the parent. We know that that parent is that constant, or that family is that constant. So we want to make sure that we do not cause any psychological distress or increase fear or any issues by pulling that parent away. We also want to promote a sense of control, as well as minimize injury and pain. So if the child's routine is that they sleep with lights at bedtime, allow them to have their lights on at bedtime. That will help to minimize their distress. If they normally have a procedure done in a certain way and you can accommodate that, do it. That's going to minimize the distress. When we talk about preparing them for a hospitalization or preparing them for a procedure, we do this best when we meet them at their developmental level and we interact with them appropriately. So, your role as a pediatric nurse is to make sure that you develop a therapeutic relationship. We can do this by making sure that we're talking with our families appropriately, that we're not crossing any professional boundaries, that we're using open-ended questions, that we're using active listening. We want to make sure that we're advocating for our patients. Lots of education and health promotion. I talk about a lot of primary preventative care, right? Primary care, secondary care, tertiary care, something that we teach in fundamentals. Primary care is usually your preventative measures. With kiddos, you want to do a lot of preventative measures. This is going to be, making sure that they're getting education on good nutrition, on good oral hygiene, on vaccines, on safety things, right? Because if we don't do all those things and we don't do good prevention and good promotion, then we're at risk for developing other issues, whether it be, they didn't get their annual flu vaccine and now they have the flu, or maybe it's, that they weren't wearing their helmet and now they have a head injury. So we want to make sure that we're preventing. And obviously, education is a huge part of it, injury prevention, counseling, collaborating. Sometimes when people that are used to with adults start thinking about kids, they don't really realize that all the therapy services are available for kids like adults. So you can have respiratory therapy collaboration, um, physical therapy, occupational therapy, but then we also do things that we don't always do with adults, like play therapy and diversions and stuff like that. And then always ethical decision making. And I talk about ethical dilemma on this slide. So with kids, a lot of times we see ethical dilemmas arise. It can be parents, nurses, physicians, and other healthcare team members that reach a different but morally defensible decision um, regarding a child's wellness outcomes. The three competing moral values that we usually look at is autonomy, which is the patient's right to be self-governing. Now, non-malfeasance, which is the obligation to minimize or prevent harm. Benevolence, which is the obligation to promote the patient's well-being, and justice, which is the concept of fairness. As nurses, we must determine the most beneficial or least harmful action within the framework. Um, we need to maintain a professional practice standards, follow the laws, follow our institutional rules and regulations, respect and understand the family's value system, the family's religious traditions, and then always be mindful of your own personal views and values and don't impose those on others. So moving into evidence-based practice. Evidence-based practice, I always think about Florence Nightingale and how, before evidence-based practice was a thing, she's the one who really like came up with it, because if she was caring for those soldiers and she noticed that the soldiers who had wounds and were in like their bandages were dirty and the environment were dirty, they had poor outcomes, and then the cleaner they were, the better outcomes they had. And she kind of was like asking that question, like, why are some doing good and others aren't doing well? And then she kind of started searching for evidence, and she started realizing that cleaner environment, better outcomes. And she analyzed that, and then that became like our process for asepsis and clean environments and hand washing and all that great stuff that follows behind it. So that's kind of just a quick overview of, evidence-based nursing practice. And then how we implement it very often today is through our nursing process. And in nursing school, everybody despises making care plans, but really, when you graduate and you actually are caring for patients, very often you're doing this. You just don't even realize that you're doing it because you're not poring over your textbooks anymore. So, assessment, remember when you're doing the assessment, this is not just your head to toe physical assessment. This is also your objective measurable data like your labs, your diagnostic studies, vital signs, as well as subjective information that the client tells you. Diagnosis sometimes is also called concepts. these are going to be the problems that we identified. So after we do all of our assessment, all of our data collection, we kind of need to look over that and see, is this patient suffering from like maybe a risk for injury? They're having pain, maybe they have impaired mobility. And then we're going to cluster that data to support that concept. And then at that point, we'd start planning. And when we're planning, you always want to plan the outcome, what you want to achieve, and then you plan the intervention that's going to meet that outcome. And then we implement, which is the action phase. And then we evaluate, like, did we meet the outcome we wanted? Yes, no, maybe why not? How are we going to change this? How are we going to improve? So that's the nursing process in a nutshell. In my fundamentals lecture, I have much more in depth on that. Your book then goes into the 6 essentials of cognitive skills and clinical judgment. Cognitive skills and clinical judgment, these are heavy on your NCLEX, and they kind of align with the nursing process. So when we talk about recognizing cues, cues are the elements of the assessment data that you are collecting. So you need to be able to recognize what's a normal temperature and what's not a normal temperature. And then you need to analyze that and say, okay, this is an abnormal temperature. How is this impacting my patient? You need to interpret the data related to your client's condition. And does that data support or contradict a particular cue in the client's situation? Um, and then once we get all that, then we start to prioritize our hypothesis, right? For this skill, the nurse needs to examine all the possibilities about what's occurring in the client's situation, the urgency and the risk for the client's consideration and possible health condition. And the nurse condition determines which client conditions are most likely, most serious, and why. So again, it's kind of like saying, all right, we have all these different diagnoses or concepts. Which one of these is the most important? All right. So if you have somebody who maybe they're coming in because they have pain in their foot, and you take that sock and shoe off and you see, oh my, this is like they have a big wound here. Maybe they stepped on something and they didn't realize it. And now they have this, big wound and it's red and it's angry and it's starting to climb up their leg. Okay. So what's going to be the most important? Is it going to be the safety? Is it going to be the pain? Or is it going to be the infection? And when we're looking at that, the infection is what is going to potentially lead to a sepsis outcome and death. So, of course, we want the patient to be safe. We want the patient to be pain-free. But the most important thing at that point is going to be that infection getting worse that can lead to death. So then we want to generate solutions. When we're generating solutions, this is identifying our expected outcomes using those hypotheses, and the nurse is going to plan outcomes, actual or potential evidence-based actions that should be either implemented or avoided and considered. Some actions we know could be harmful to a client depending on the situation. Then we're going to take action, then we're going to evaluate. So this is very similar to your nursing process. It's just different terminology for it. And that is the end of chapter 1. Thank you for joining us, or me, or whatever.